All right, good morning, everybody. Welcome to Department of Medicine Grand Rounds. Today, we're excited to have Dr. Dennis Chang, one of our very own hospitalists here. Dr. Chang received his BS from Yale University, his medical degree from University of Chicago, and then completed his internal medicine residency at NYU. He then joined the Icahn School of Medicine at Mount Sinai as faculty. He served several roles at Icahn as he rose through the ranks, first running the medicine consult service and the peri-operative clinic, then serving as the IM clerkship director before becoming the associate division chief of hospital medicine and the director of education. As kind of evidenced by these roles, Dr. Chang has developed his career focusing on improving medical education, faculty development, and interprofessional experiences. He's developed medical school curricula on a variety of topics, including patient safety and quality improvement, leadership, teaching skills, and the business and law of medicine. He's also created teaching courses for faculty focused on mentorship, communication, and career development. His impact has been felt at multiple levels, from giving lectures on these topics at national conferences and meetings to being elected to the Faculty AOA Society at the Icahn School of Medicine. We're lucky to have him join our division of hospital medicine in 2018, where he's continued to support educational and leadership endeavors at all levels of medical and interprofessional training. Currently, he is the Interprofessional Educational Thread Director and the Co-Director of the Inpatient Clinical Immersion here at WashU. Today, he'll be talking to us about effective bedside teaching. Please help me welcome Dr. Chang to Grand Rounds.
Well, thanks for having me here, and I'm going to be talking about something about effective bedside teaching. But before we sort of get into teaching in general, I wanted to sort of back up and think about what is the goal of teaching, right? Why do we spend so much time doing it and talking about it? And so what I want you all to do, if you can, early in the morning, is actually write up here, either on the website or text or use a QR code, what are the characteristics of a great physician? Because at the end of the day, our end goal for teaching, I think we would all agree, is that we want learners to become great physicians, right? Our students, I see some senior residents in the crowd, you want to teach your interns to be great physicians. So what are those great characteristics? I know this is a common question, but just so that we sort of get our minds thinking in this realm. All right, so I think a lot of stuff, people talking about empathy, caring, being lifelong learners, compassionate, being able to synthesize, listen, okay? And we'll come back to this, but I think one theme you can sort of see here is that most of this stuff is stuff that you would do at the bedside, right? Majority of this are things that we are thinking about a great physician is how are they at the bedside, okay? And so we'll come back to this concept towards the middle of this. So what I want to do is, number one, define what bedside teaching is and what it is not. Summarize some of the current debate around bedside teaching, because it is something which I'll show you some facts that is not happening as much as it used to. And lastly, use that in thinking about what are the things that are barriers to bedside teaching, to think about how do we actually do this effectively, right? How do we effectively teach the skills that you all wrote up on the screen? And how do we do that really well so our learners do become great physicians? So I always start my talks with take-home points, and we'll come back to these, but I think number one is the perceived barriers we have to bedside teaching are just that. They're not really true barriers. And part of how we overcome those barriers are setting shared expectations, making a daily lesson plan, and really leaning into this idea of role modeling, because what you all shared up there, those are very hard to teach, right? And some of the best ways to teach those are through role modeling. So let's define bedside teaching. So I've given parts of this talk maybe for the last decade or so, but this Grand Rounds really gave me an opportunity to dig into the literature a little bit. And it's really interesting to sort of think about how people really define bedside teaching. And so what is truly considered bedside teaching is summed up in this phrase. It's the process of active learning in the presence of the patient, right? And I think that's the key part, in the presence. And there have actually been some randomized controlled trials looking at the effectiveness of bedside teaching versus hallway or classroom teaching. And how they really define it in the nuts and bolts of it is it's really presentations at the bedside, performance of one physical exam skill one way or the other, and development of a patient's plan of care with the patient. That is truly what is defined as bedside teaching, okay? Now this probably looks familiar, and I do this too, right? Which is hallway teaching, right? We do all the stuff at the hallway. We kind of go into the patient's room. We sort of talk about the plan. Are you okay with the plan? Okay, cool. Walk out the room, right? I think that's good. I don't think that's bad, but that's not truly bedside teaching, right? The other thing that I'm not going to really get into is sort of this interprofessional rounds. There's a lot of evidence that this is really valuable for patient care, for quality of care. But that's not really bedside teaching necessarily. That's really sort of like team building, patient-centered care. What I'm really talking about here with bedside teaching is this, right? When we have all of our learners on our physician teams together, talking to the patient, presenting physical exam skills, discussing the plan together with the patient. This is bedside teaching. So just to sort of frame our minds when I'm talking about bedside teaching and looking at the evidence, all right? And you can't do any bedside teaching talk without my obligatory Osler quote, right? There's always an Osler quote when anybody talks about teaching, right? But I use this just to sort of show that, just to remember the history of this all, right? Prior to Osler's books and sort of his push to this, a lot of teaching in medical education was in the classroom. It didn't occur at the bedside. Clerkships, residencies, that was pushed forward in the early 20th century. And so at that time, that was sort of what everyone was doing. And in the 1960s, it still was the major way that we taught learners. About 75% of time was spent at the bedside. Now, fast forward only about 14 years, and studies show that this was only occurring 16% of the time. And fast forward to now 2009, where many institutions have hospice teaching. They've sort of watched the hospice, and they looked at the actual time at the bedside. This isn't even bedside teaching. This is just actual time at the bedside, and it was about 17%. So the debate becomes, is this a positive adaptation to changing times? I mean, we always quote Osler, but in 1900, there was no EHR, right? There was limited data. There wasn't all the imaging that we have. We have a lot of stuff that we need to do now that wasn't apparent then. So is this just an adaptation to the times? The fact that there's so much data to review, there's so much other things going on? Or is this sort of an erosion of the learning? So I'm going to sort of walk us through some of the evidence around this. There's not really evidence, but just sort of like opinions about this, and a little bit of evidence as we sort of think about this. And then hopefully sort of going through the things that are sort of talked about why we don't do it, kind of walk through why those are not really true barriers as we think about how do we do this really well. So what is the argument for bedside rounds? And the first one that you'll see a lot is this theoretical argument, okay? So I actually punched this into AI too, and it actually really is in line with what you all wrote, okay? So what is sort of commonly said is, like, why do we do bedside teaching? The reason is because if we think about what we want our learners to be, we want them to be lifelong learners, right? There are several things that were put up on the poll everywhere. Number two, we want them to have strong communication and interpersonal skills. Again, very in line with what everybody in this room wrote. We want them to be able to adaptable, to integrate technology. We want them to have a patient-centered approach, have empathy, compassion, and we want them to have strong leadership and teamwork skills. Again, all of these things are things we do at the bedside. And for those of us who are like in the education world, we all sort of adapt this idea of adult learning theory, right? Which is that we learn by doing. We learn by doing the things that we're asked to do, right? So if we want them to be compassionate, we want them to have good communication skills, they have to do that at the bedside. We have to teach that at the bedside. You can't teach it in a classroom, right? So that's one of the arguments for bedside teaching, is that in order for us to really develop great physicians who have patient-centered approach, great communication skills, lifelong learning, that has to happen at the bedside. What about teachers? What about the great teachers that we have all across the country? What do they say? Why do they think that this is important? So there was a study done in 2013 where they actually interviewed 34 faculty from 10 institutions. And these are all the great institutions we think about: Pittsburgh, UPenn, Yale, Brown, all these institutions. And they actually had those institutions pick their best teachers. Who are the teachers winning awards? And those teachers usually were actually rounding more than 3 times at the bedside. And they interviewed them, and they asked them, hey, why do you do this? Why do you put all this effort into doing bedside teaching? Why do you think it's important? And what they found is they all coalesced around several concepts, right? And it's very similar to what we've been talking about. First, they felt that at the bedside, they could really see the skills of the intern, resident, or student. They were able to then give them pointed feedback. They could observe these things, give them feedback, role model the way we want it to be, and then continue that cycle over and over. So to truly teach compassion, communication skills, teamwork, that all could happen at the bedside. The second thing they thought that was really, really helpful about the bedside was team building. They really felt that at the bedside, the patient, when the students were, or the residents were presenting, the patients really got to know the team. And the patient felt like they were part of the team because they were talking about the plan together. The other thing they felt is that it actually improved patient care delivery because they were able to come to a consensus about the plan together with the patient. And I think this next quote really sort of sums up that idea, right? And I think we've all been here, right, where the intern or the student gives you a story and you're not at the bedside, and then you actually go in front of the patient and you're like, wow, this is totally not, this is not what I was thinking, right? This is not the patient I was thinking about, okay? And so I think that this quote about, I've always been struck how I hear about a patient in a conference room, then walk in the room and the story doesn't match what I see. I say to myself, here's a good example of why bedside rounds are so good. You can really hone in on information quickly and correct misinformation. And I think that's one of the keys of bedside rounds is there's nowhere to hide, right? They have to present the patient. If there's misinformation, you can correct that, right? Oh, why did we get to that conclusion? Or why did we think that about the patient? And you can look at the patient, examine, and check the information. And honestly, it saves time. And I will say that I have found this as well, okay? And the last thing that they talk about is sort of this idea that it really creates this culture of patient-centered care, right? Because you really have the patient themselves actually being part of the plan making. And it really emphasizes the idea that, hey, we are spending time at the bedside because this is important, because patient-centered care is important. If we want a role model that, hey, we want you to spend more time at the bedside, then we ourselves on rounds have to do the same thing. I think the other way that I would say this culture of medicine, how this all comes together is, how many of you guys have ever had a patient who comes in with altered mental status? Yes, okay. And how much time do you spend in the hallway or in the conference room talking about, wait, are they really altered? What's their mental status really like? You spend 10 minutes talking about that when actually if you just stepped into the room, everyone would get an idea of what that is. Because the mental status also changes most of the time. They saw them at 5 in the morning, you're seeing them at 9 in the morning, it may be very different, okay? And so that is where sort of this magic of bedside rounding can really occur. What about outcomes? So I'm not going to go through this data because it's boring, and frankly, it's so varied in terms of what they measure. There's all these studies looking at what the learners agreed, did they self-report all these things. It's so all over the place, it's kind of dizzying. But I think the point I want to say, and I don't want you all to really look at this too long, is that if you look in the direction of the effect, it's either equivocal or it sort of favors bedside rounds. Now, I can't tell you that you really are improving learner outcomes, but I think there might be all this evidence together might be pushing us that there might be some better learner outcomes. So that's sort of the argument for bedside rounds and spending all this time doing it. What about the concerns, right? What are the concerns? Why don't we do it? It's not because people are lazy and they don't want to do it. There's concerns, there's barriers, and legitimate concerns. So that same study actually interviewed these teachers, and they said, well, why are other people not doing it? Why do you find it challenging? Okay? And what they really coalesced around was 5 ideas. There was physician-related, there are some systems issues, time, which is always an important one, patient-related concerns, and then a culture shift. And just to dig into these a little bit more, physician-related issues were just people felt the lack of bedside skill. People were nervous about doing it. They weren't taught this way, right? So if we look back, way back in 1978, it wasn't happening as much as it used to. So people felt that their bedside skills weren't as good, so they don't want to teach about it. There's a lack of comfort for everybody. The residents and interns weren't used to it. They didn't do it as students, and so people sort of shifted away from it. There was also this idea that it was inefficient. The residents themselves weren't used to it, so they felt like it was inefficient. Systems issues, right? Shorter length of stay. The length of stay now is so much shorter than it used to be, right? I mean, we used to keep people in the hospital for a week, 2 weeks, titrating meds, stuff like that. That doesn't happen anymore. Higher patient volumes. There's all these patients on isolation, right? How do we bedside round when we're all in isolation gowns? Okay, so those were some of the barriers. Time, right? There were no work hours in 1901. Now we do. Rounds have to be shorter, right? No longer the 4 or 5 hour rounds. We have to try to keep it to 2 to 3 hours. That's limiting, right? And people think it's inefficient, right? Bedside rounds just take too long. It's just not something I want to do. And then there are legitimate concerns about patient-related concerns, right? They're much more acute. What about privacy? What about, they don't want sensitive information shared. We have double rooms here at Barnes, right? We talk about sensitive information. The person's literally next door with a curtain. And then we think, hey, there's a lot of anxiety and stress that the patient might feel. How about the students and residents? What's the argument from their side? So they actually did an interview of a bunch of students in Penn State. And what they found is that only 24% of them actually wanted bedside rounds. The learners themselves don't want to be there. Interestingly, though, those students or residents who had a rotation with bedside rounds were more likely to want bedside rounds. So maybe they like it. You can sort of change their minds, right? And they also had very similar concerns about bedside rounds. And thankfully, a lot of them were patient-centered, right? Just sort of thinking about, hey, I just feel like it's not comfortable to do that. But what I also found really interesting about this study is when you ask them, bedside rounds are important for learning which skills, they pointed to many of the same skills that we wrote, right? So they do see a value, they just feel uncomfortable or they have reasons why they don't think it's the right thing for the patient. All right. So how do we overcome these barriers and why do we think this is important? So obviously I'm giving a talk on effective bedside teaching. I'm going to be for it, right? So let me try to convince you why that is. So I think bedside teaching, we have to think about it in a little bit of a different way, right? The way that Osler did it, the way that we did it way back when, is probably not something we can do these days. So I always think about it more as what is the effective modern way to bedside teach? still get the things we want out of it, while still understanding that there are legitimate concerns around this, all right? So as I talk to you about, hey, what are the ways we can sort of address these barriers and still be effective at the bedside, let me walk through why I think some of these perceived barriers can be overcome. So let's talk about the physician-related, right? I will just tell you, there are many, and I'm sure everyone in this room, there are many things I don't know. There are topics that come up where the resident or student is like, oh, this person comes in with whatever, and I'm like, wow, I am not good at that subject, right? Rheumatology, right? Neurologic stuff. I'm like, whew, like, I hope this is really easy, right? And so same with bedside skills, right? There's obvious things we don't do well, but we can get better at that, right? And so one way to sort of get over this idea of like, oh, everyone feels uncomfortable at the bedside is one to just create a safe environment, right? We all know how to do that. The power of I don't know, just sort of creating this idea that we're all learning together, right? So yeah, it's a little uncomfortable at the bedside, but hey, we can all get better at this. This is really important. And setting expectations about what bedside rounds will look like, right? So one of the things that's really important when you set expectations is the first day when you sit down with the team, you say, hey, I like to do bedside rounds, but I don't want to do it on all the patients. So tell them, which patients do we think we should see at the bedside, right? Just so that they know it's not everybody, right? That can alleviate some anxiety. And I think it's important to tell them why. And we just went through a lot of the why. Hey, I want you to be a great physician. It's really important to me that we learn how to communicate with patients and physical exam skills. Tell them the why, right? And then also tell them what it looks like, right? It's much easier to feel comfortable doing something if you can kind of give them paint a picture of what it will look like, right? One of the biggest anxieties for me whenever we travel as a family is like, I don't know what the place looks like, right? I don't know, like, is there food? Where am I going to get water? All of these things, right? So paint a picture of what it will look like, and this can give them the answer to why. So there are a lot of opinion papers from great teachers talking about how you stage this, right? And so one of the ways to stage this is to tell them where they're going to stand, okay? So ideally, you have the attending on one side, and you have the presenter on the other side, whoever that is, the student, the resident. You have the remaining team sort of around. There used to be this idea of the runner, right? And so this is the days of the pager, where you give somebody else the pager so that they could present, right? Now everyone has it on their phone. So this is a little bit different now. But I think the idea of having the attending and presenter on opposite sides is really important, because if we are wanting to teach about communication and observe and give feedback, this position allows the attending to not only see the patient, but also see the presenter. And by doing this, they can understand the relationship between the patient and the presenter, right? So you can see all this, and hey, we all have to fill out evaluations for our learners, right? And what do they always ask? How do they communicate with the patients, right? What's their relationship with the patient? You can actually see it happening, right? You have all been in a room where you're like, wow, there is a great connection between this student and the patient, right? And you can see that. And when they're presenting the patient, you really see that happening. You can really see the interactions. So if you sort of give them this idea of like, this is what it's going to look like, and this is why I'm doing it, I think that can alleviate a lot of concerns and lack of comfort around bedside teaching. The other thing that I think is important about expectations for rounds is not just giving them an expectation of what's going to happen overall during the rotation, but also give them an idea each day how it's going to look, right? So a little pre-round huddle. Hey, who do you want to see today? Which patients do you want to see? Allow them to have some choice in that matter. And then sort of say why we're going to say, hey, I want to see this patient because they're a new admission, or I want to see this patient because I have a cool exam finding, right? But be flexible. This is the modern era, right? Sometimes they have acts, they have all these things going on. You may have to abandon the bedside teaching. That's okay, as long as you try to do it as much as you can and give them the why. All right, so the barriers of physician-related, I think setting expectations, creating that safe learning environment can go a long way to alleviating that barrier. What about systems issues, right? And I think that this goes back to what I said before in setting expectations, is that patient selection matters. I don't think we can go around and do bedside teachings for every single patient on the list. That is not realistic. That would take forever and probably not really within work hours. But really targeted bedside teaching. Who are the patients that we can really high yield teaching happens at the bedside? Things that have to happen at the bedside, right? The patient who's there for, 2 weeks waiting for their antibiotics because they can't go home with it. You don't need to see that patient every day, bedside teaching, right? But the new admission would be a great person. A patient who's sick, right? That's a great bedside teaching. That's nothing, we always say, hey, we just want our interns to know who's sick and who's not sick. How do we know that if we're not there at the bedside, right? So that's a great patient to see. Someone with physical exam findings that are good to demonstrate. Ones where there has to be big decisions made. Those are good places. And you don't have to see all of these patients on your list every day, but here's like some criteria of ways that, hey, these are the patients I want to see at the bedside, setting that expectation. So I think that can help with the idea of work hours, shorter lengths of stay, and trying to be very targeted with our bedside teaching. Okay, the last one is time, okay? So there's this perception that bedside teaching takes more time. So this is that same article that's Systemic Review, looking at all these studies. And a lot of them looked at what is the time difference between bedside rounding, hallway rounding, conference room rounding. You can see that majority of them, there's no difference, okay? And I think that there is some efficiency, right? You don't spend time talking about what does the patient look like. Is that really true or not true because the patient is there telling you those things, right? The only one that thought that there was longer, bedside rounds took longer, was actually a perceived length of time, right? So the people in the room thought it was longer. And actually there was a study showing that patients think that you're in the room longer, which is actually a good thing, right? So there's a perception that it's longer, but it's not actually real, okay? Lastly, the patient-related stuff, okay? So I personally think that these are things we think for no reason, right? There's things we do for no reason. This is probably something we think for no reason, okay? And I'll get into a little bit of the data, but I wanted to sort of talk about this patient privacy one, right? And I think it's important, right? We have to be sensitive to sensitive things that the patient may not want others to know. But let's be perfectly honest. Those two patients that are in a room together, do you think they know each other pretty well? They share a bathroom, for God's sakes. Who do you share a bathroom with? Your significant other, your children, right? You know them, right? So I bet you that a lot of the things we think are sensitive, they probably are already sharing with each other, okay? Obviously, there are things we know are really sensitive, and maybe we ask the patient, hey, is it okay if we talk about that right now with everyone in the room? I think that's obviously a great way to role model being culturally sensitive, all those things. But I think this idea that the other person in the room doesn't know the patient is probably false, okay? Now, there was a study where they actually asked the patient's perspective on bedside rounding. And what they found is that the patient actually perceived the time longer, which is a good thing. And they honestly thought it was positive and satisfying, and really rounds didn't cause much worry. So, conference room bedside, the patient's just as comfortable with both. So if we think that we can better teach certain skills at the bedside, why not do it? The patients are fine either way. There's another study, which is an interesting one, where they actually drew norepinephrine levels before, during, and after rounds, and those were all the same, okay? Their blood pressure was the same. So physiologically, they also feel pretty good either way, okay? So I think this idea that the patients are, anxiety, stress, or they don't really understand what's going on is not really true, is that in general, they probably are fine either way that we do it, all right? So hopefully I've sort of convinced you that some of these barriers can be mitigated very easily. And so let me switch gears into what are some really good ways that we can effectively make these sessions really effective for the students and the learners and the residents and everybody in the room, including the patient. So there's a study where they actually, again, took residents and students and asked them, hey, what makes rounds successful? What makes it really helpful to you? And what they found is that they all coalesced around 5 big categories, right? What made successful attending rounds? Learning atmosphere, communicating expectations, team management, teaching style, and clinical teaching. I think what's really interesting about this is that the majority of it is not actually the clinical teaching, right? It's how you manage the team, how you communicate expectations, the learning atmosphere, and how you do it. And what's really interesting is if you look at the top 8 things that the students and residents felt made attending rounds really successful, they're all things that are very easily done at the bedside. Teach by example, bedside manner, right? That's bedside teaching, role modeling. Sharing of attending's thoughts processes. That's also something you can do at the bedside. Be approachable, not intimidating. That's sort of a larger idea of creating a safe environment, right? So trying to decrease the discomfort. Insisting on respect for all team members, which one of them is the patient. And we have to make sure that we insist respect for everybody on the team. Conducting rounds in an organized, efficient, timely fashion. Stating expectations for the resident students, showing enthusiasm, and allowing team independence in decision making, okay? So these are the core things that you can do at the bedside that really can make attending rounds really effective. And these same things can be done in the classroom or in the hallway, whatever it is, but I think that these are things that can be done very effectively to make bedside teaching very effective. So I'm going to break this down into how you do this. How do you specifically make bedside rounds really effective? So I break it down into what you do at pre-rounding and what you do in the patient room, and then I'll talk about democracy as a part of bedside teaching. So first, for the 3 things that you do pre-rounding, right? Be approachable, easy to contact, set expectations, which we've talked about, and then how do we lesson plan? So I think everybody in this room does this, but I just want to sort of hit this point home, right? Being approachable can really create a safe learning environment and make bedside teaching not so intimidating. And the idea is to really decrease the distance, right? We have to remember that our students and our residents, or as residents in the room when you have students, do you all remember when you're a student, the resident, you were like, wow, this is the most amazing person, right? You're like, this person is a 3rd-year resident. They know all these patients. It's so amazing, right? So there's this perceived sort of hierarchy because they think that you all are so much better than they are, right? And so how do we decrease that psychological distance and make it safe for them to speak up? They don't want to look bad in front of somebody they really respect and want to know that they're good, right? So decrease the distance. So as much as you can, share professional experiences. Share with them that, hey, I was really uncomfortable at the bedside. It's gotten a lot better, right? Share your own personal life. You know, that's a great way to sort of decrease that distance so they don't feel uncomfortable at the bedside. You don't have to overshare, right? You don't want to be the thing where like, that guy shares way too much, right? Just share certain things about yourself. I think that's really helpful. Ask about the lives of learners. Hey, how was your day off? Hey, how's studying for the shelf? All those like silly things that honestly are just niceties, right? But it helps them feel more comfortable at the bedside, right? Because they're already uncomfortable presenting all these patients. Social outings, group reflection, and I think we'll talk about admitting mistakes at the end. But again, the power of I don't know can be really powerful, especially at the bedside where we know people are already kind of feeling a little uncomfortable. All right? And then just a tip about being approachable. You know, I think we all do this, but just please, I think it's really important to share your cell phone and no strings attached. I saw this video about teaching one time, and the example they gave was an attending, and she sort of was like, hey, just call me anytime. I'm going out to dinner with my friends. I may not be able to pick up my phone, but yeah, call me anytime, right? Like, don't have any strings attached. Just call, text anytime, right? So just a little tip on that. Okay, so let's really get into this part about pre-rounding, right? So we've already created setting expectations day 1. You've been approachable. You're easy to contact. What do we do with the lesson plan? So prior to bedside rounds, I think it's very important that we as the teachers prepare, right? And what do I mean by that? We all do it. We all stealth round, right? Nobody wants to look silly on rounds, right? So you look at all the patients. Everybody does it, and you should do that. But in terms of what you do is you should think about, hey, which patients do I want a bedside round on? And what are the 1 or 2 topics I want to talk about? What are the 1 or 2 topics I really want to hone in here at the bedside, right? Maybe it's like, hey, this person's got a physical exam that I really want to go over. We have a lot of liver patients. That's a great physical exam thing to go through at bedside, right? Pick 1 or 2. And then map out your teaching session a little bit. How are you going to do it? When are you going to interrupt them in their presentation to talk about a differential? When are you going to do your little talk on physical exam, right? Plan out how the rounds are going to go. Where am I going to role model? What are the things I want the students to learn, right? So think about that before you get to rounds to make it efficient and make it really high quality and effective. Now, a couple tips about what we do at the bedside. So number 1 is that one of the best ways to engage our learners is to ask questions, right? We ask questions of all the learners. So just a couple tips on this. First, when you think about the questions you ask, think about what level of question you are asking and who you're going to ask that to, right? So there are 4 sort of general levels of questions. There's recall questions, which are just facts that might be good for an early 3rd year for clerkship or phase 2 student here. Analysis synthesis, how do you take that data and come up with a diagnosis? That's something you might ask an intern, right, or a resident. How do you apply this, right? Well, how do you treat this patient? That might be an intern resident level question. And lastly, how do you self-assess? What evidence can you bring into this discussion? Why do we do this, right? That's sort of a higher level, senior level question. So as you plan out your lesson plan and how you're going to engage the team, think about what level of question you're going to ask and to who. The other tip, which I'm sure a lot of people in this room know, but just important for me to remind you, don't ask the intern a question and then ask the student the same question, right? Nobody wants to be embarrassed by somebody who's not as experienced as them, okay? Don't ask the intern a question and then don't ask the intern a question and don't ask the resident a question and then go to the intern, right? Try to keep it going up the chain, right? The other tip I would say about asking questions, and this is really an important one and something that I had to learn, is you really need to wait 5 seconds for an answer. If you're going to ask a question, you got to wait. The data shows is that people, when you ask them a question, it takes 2 or 3 seconds for them to process it, and then another second or 2 to think about an answer. So we're going to do this for a second. And obviously, you're not going to take out your phone and look for 5 seconds, okay? That's sort of ridiculous, okay? So what I always think about is when I start feeling uncomfortable, then I wait a little longer, probably even twice as long. And that's probably the right amount of time. And what you'll find, and this has happened to me a lot, is it's so uncomfortable that eventually someone will just say something. It may be out of left field. It may actually be correct. And I think there's so much value in having someone just say something, because also it helps you understand where are they in their learning journey. It will help you understand, hey, this is where they're having an issue. Here's where I can help them, okay? So if you're going to ask questions, make sure you wait for the answers. All right. So that's how I think about the lesson plan. I really think about how am I going to actually engage the audience. And then how about in the patient room, right? If we're in the patient room, what are we doing in that room and how are we making this effective? First off, right, everybody know who this is? Bueller. Okay, so obviously we don't want to be him. So one of the things, just if you have enthusiasm at the bedside, everybody has enthusiasm at the bedside. Okay, so that's number 1. Number 2 is if you don't have time to lesson plan anything, if at the very least, when you walk into that room, think about what you're going to role model. And it doesn't even have to be anything specific to the patient. It can just be general things so that we ensure that everybody understands the right way to communicate, right? So one of the first things you can do, how do you introduce yourself to the patient? How do you introduce yourself to the members of the family that are in the room, right? If there's an interprofessional in the room, how do you introduce yourselves to them, right? How do you interact with them? These role modelings are so powerful for our learners, okay? The other thing that I do, and this is just selfishly, is it actually helps me learn everybody's name. Because what I do is I come in the room and I say, hey, I'm so-and-so, we're gonna do these kinds of things. And I'm gonna let everyone else on the team introduce themselves. It's like so helpful because honestly, after the first day or two, sometimes I'm like, I don't really remember their last name, right? And so just allowing them to do that can help everyone learn everybody's names. Because if you're thinking that, probably other people on the team also can't remember everybody's name, okay? I think it's also important in terms of really showing us role modeling patient-centered care is to tell the patient, hey, how do you introduce bedside rounding to the patient? This is really important. We want to make sure you're involved in the care, right? That sends a very powerful message in role modeling to the team and what is important to you, who is the leader of the team, right? And you always ask the patient, hey, I always tell them, hey, we're going to talk about you. So-and-so is going to talk about you. Please, if you have any questions or if you have any things you want to correct, please let us know, okay? How powerful that is for the team and everybody to understand how important that is, right? And then obviously always asking what questions and then summarizing the plan for the patient and asking for the patient input. All of these things you can just do at the bedside, right? Even if you don't have time to remember what you're going to teach, these things are powerful. So the power of role modeling cannot be overemphasized. What else can you do at the bedside, just purely role modeling? An exam skill, right? How many times have you seen students listen over a shirt, right? If you spend the time to get the patient comfortable so that your stethoscope is on the skin, how powerful is that for the student or for the interns or residents, okay? Challenging interactions. This has happened all the time, right? You think the patient's good to bedside, you walk in and you're like, whoa, this patient is mad, they're angry about something, right? And how you interact with them, how you sort of talk to them, how you make it patient-centered, so powerful for them to see, right? They learn about this, but they don't actually see it in action and see what it looks like. Self-directed learning and the power of I don't know, okay? There's nothing more powerful to see for an early learner than for the attending, the patient asks them a question and they say, I actually don't know the answer to that, but I will find that. And if you go back, find the answer, come back to the team, that's so powerful, right? That shows them what it really looks like to be a lifelong learner, to use evidence-based medicine. I always tell this story is that I remember I was teaching about an exam thing, and somebody asked me a question, and I answered it. I think it was about a murmur. And then everyone just accepted it because I was attending. And then after rounds, I was like, I'm totally wrong. That was totally not correct, what I just said. And then the next day, I came to them and I said, hey, I just want to apologize. I did this, I said this, it was totally wrong. Here's the evidence why this is the right way. I mean, that's just hugely powerful, right? It doesn't make you look any worse. It makes you look that, hey, this is how I want you to learn. You're gonna make mistakes, right? And so being able to do that at the bedside is just something that you can only really do with the patient and the families at the bedside. Okay, the other thing, when they're doing their presentation, okay? Let's just put it all out there. Sometimes when they're presenting, I think we all go off into another space, right? That's okay, it happens, we're humans, okay? So what do you do when they present? So one of the things, and we'll come back to the thinking and reasoning aloud, but the things I always think about is the following. Let them speak, number one, okay? It's very hard when you continue to interrupt them at presentations because you never get into a flow. You never get an understanding of how they're thinking. Try to limit your break points to 1 or 2, and that might be something you think about before the presentation. Take notes, okay? Even if you're not listening, take notes about something, right? Just so that they can show that you're listening, right? And don't just take notes about the patients, take notes about how they're presenting, right? if we're going to really give them feedback, maybe take notes about how they're interacting with the patient, right? The students and residents, they always want feedback. This is targeted feedback at the bedside, right? That's what you can do at the presentation, right? Because sometimes people present, they give you 2 lines, you're like, I already know what this is. I don't even need to listen to the rest of it because I've already read it before. So let me just really observe what they're doing, okay? And that helps keep me a little engaged as I sort of drift off into other things, okay? So take notes. Watch the patient interactions and start thinking about feedback, okay? So that's what you can do at the bedside. The other thing which I think is really important, and I said this in the earlier slide, is this idea of thinking and reasoning aloud, okay? This is something that you can always do at the bedside and really allows learners to understand what's going on. If you don't know the answer, just reason it out. This is how I'm thinking about it. Even if we don't get to the answer, that's really important, right? That's why I have CPC. CPC is literally this. Just bring that to the bedside. How do we think about this? How do we reason it, even if I don't know the answer, okay? And you can do that during the presentation. You can talk about those things during the presentation. And then the last thing I want to talk about in terms of bedside teaching and how this can be really helpful and how it helps with team building is let them make some decisions. Give them a voice. So at the bedside, as you're talking about the plan, let them make some small decisions, right? Hey, what do you want to do with the potassium? I noticed it's low today. Do you care if they give 60 or 80? Not really, right? It's probably fine, right? But it allows the student to make a decision. And that's really impactful in front of the patient so that the patient trusts that, hey, everybody on this team is working together, right? And it allows the learner to feel that they are making some decisions, okay? We all make a lot of decisions now. We're all like physicians who've been around a long time. But you can all remember that first decision you made and how like you're like, oh, wow, I actually made a decision. I'm like a doctor. I like made a decision, right? So give them that power of things that aren't as necessarily hugely important, right? I always answer a question with a question. Do you want to get the CT? They're like, oh, I want to do the CT, blah, 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 blah. What do you think? You make the decision, right? Reason that aloud with the patient. And I can just tell you that this decision-making that happens at the bedside is so great for the patient to see. Because we, as internal medicine doctors, we don't do those like cool surgeries, right? We're not like, hey, we're going to do this, you're going to get better, right? Our procedure is here. How we think, how we reason, how we make decisions. Why are we making these decisions? And having the patient see you all do that at the bedside and having them involved in that decision makes everything better. The patient understands why you're doing what you're doing. They know you're spending all this time and mental energy thinking about them specifically, okay? So doing these things at the bedside can be really powerful, all right? Last thing I'll say at the bedside, make sure that you have some sort of closure. You know, whether it's outside the room or with the patient, I would advocate for with the patient. Hey, what is our treatment plan? What are the main teaching points we just got out of this? Does anyone have any questions? What questions do people have? Anything people want to add? What are things we need to look up that we didn't know? Okay, this can be a really good way to kind of close out the session and make it really effective and high quality and lasting. All right? So I'll just end with this. This is kind of how I do bedside rounds. I will admit that I had gotten away from it for several years, and probably only in the last year or two I've really come back to it. And so number one, I always set expectations from day one. What, when, how, why do I want to do bedside teaching? I set an idea with the team which patients we want to see. I always do some sort of lesson planning right before rounds. And I really try to keep on time. And really, this is like, it actually helps me be a better doctor. I really think about what are the things I want to role model for today. So role model, role model, role model. And then I honestly usually discuss the rest of the patients in the conference room, and then I see them on my own. So that's how I sort of have adapted my bedside teaching to sort of the modern era of time issues. All right, so I'll just end with the key points. Hopefully I've talked to you guys that some of these perceived barriers to bedside rounding are not really true barriers. One of the keys to overcoming those barriers is setting shared expectations. making a daily lesson plan and thinking about how you're going to engage learners and what you're going to role model at the bedside can make those teaching sessions really effective and really helpful for everybody, including yourself, and specifically the learners and the patient. All right, questions?
Thank you very much, Dr. Chang. We have a few minutes for questions if anyone has some. Yeah. Emily.
What is a reasonable time for bedside? Are you thinking 15 minutes? Are you thinking an hour? Does that have those?
Yeah.
Do you mind
If you
repeating the
look-
question too?
What's that?
Do you mind
Oh,
repeating
yeah.
the question?
So the question was, what's sort of a reasonable time for each patient in terms of bedside rounds? So actually, in those studies, the average time was actually around 10 to 15 minutes, right? And agreed, that might be, and if you really think about it, if you're talking about a new admission in a conference room, it's about the same time, right? So 10 or 15 minutes is probably the right target. Good question. Yeah.
How do you balance like plain language, documentation, along with like high level differential diagnosis? Like
Yeah.
start one part and then like explain it as you go, or
Yeah.
explain it and then explain
Yeah, so the question was sort of how do you, I would say sort of summarize, like how do you deal with jargon, right? Medical jargon, is that sort of the question? Yeah. So I think that number one is that if you are going to kind of talk shop, you can just tell, hey, we're going to really talk about this. We're going to use some words that maybe you're not sure about. Please like interrupt if you have questions about it, right? I also think it's good to role model not using medical jargon in front of the patient. I think that's another great way to do it too. And the other thing that is so cool about bedside teaching, you can see which students are good at this, right? So some students you'll see they'll present, they will say a jargon and say, and hey, so that means so-and-so, and then keep going. And yeah, it might elongate things a little bit, but I think there's a lot of value in sort of seeing how they handle medical jargon. So I think there's two ways to handle it. Either you say, hey, we're going to use some jargon, please ask questions, or you just role model the fact that you're not going to use jargon with the patient there. Does that make sense? Yeah. Marty.
So it sounds like potentially if we, well, it sounds like time-wise, maybe we're spending close to similar amounts of time
Yeah.
in the room, but potentially talking about some different topics a little bit, particularly if we're spending a lot of time like on a physical exam skill.
Mhm.
How do you navigate, what I don't want to do is go in there and then have the patient learn what an ASMR sounds like, but doesn't get the point that I'm going to have a surgeon
Yeah.
what is ASMR? Like, they don't hear everything we're telling them.
Yes.
How do you navigate kind of what you really want to get across to them?
Yeah. So I think that's where the closure can be really important, is to say with the patient, hey, we've talked about a lot of things, all these things, and hey, I just want them to say, here's the treatment plan, you know, and so to really kind of, because yeah, there's a lot that happens there. I will also say just experientially with the patients, they often are like, oh, I learned a lot about my disease just because we're talking about it. So they sort of learn about it during it. But yeah, I think it is important to sort of have closure and sort of make sure they understand what the plan is, because yeah, we don't want them to be like, oh yeah, I'm an AS and like I don't know what they're doing, right? That's probably not good patient care. So I think you can meld the two together, but the closure is important. Right.
So it's obvious why you won so many teaching awards. Terrific talk. One of the things I want to ask you about, you mentioned that you sort of laid out where people's role is and where they're standing in the room. It's a little different than what I've historically done. I don't stand as the attending at the front of the patient, because I feel that it's important to emphasize that the senior resident
Sure.
is running the team, and just wanted your thoughts about that.
Yeah. So it's interesting. There's a paper where they actually have a lot of different variations on at where the attending stands. I think it's fine. Well, I think one of them was having like the resident and the student, and then the attending was here. I think as long as you have sight view of the presenter and the patient together, I think that's probably the most important piece of it. Like you don't, I think it's harder if you're like like next to them because they're looking at you and you can't really see them because they're presenting to you. And so I think that's why I like the one where you're across, because they can look at you and the patient sort of at the same time. But I think it's okay. I saw one model with the attending sort of like at the back here, and I think it seemed fine. Yeah. Other question?
So am I inferring correctly that you take the whole team to do bedside rounds?
Yeah.
So the split rounding is not, you know, that's why
Yeah,
everyone wants to split rounds, right?
So-
It's usually a hallway round.
Yeah.
Sort of thing.
So it's interesting. I actually still do the split rounds with the bedside teaching. I still let the other intern do their thing, and then we see one of their patients at bedside. So one of the things is we do try to decide, like, hey, I want to make sure, like, each intern we do one bedside teaching. So the resident may have to deal with two, but each intern only has to deal with one or two on their own. Yeah.
Do you ever give, so there's other interns, there's med students there, do you give them like any additional roles, or are they just like, they're just there as like audience to learn, you know, from the interaction? Like, I guess like you mentioned, like there's a role of like a runner that
Yeah.
we don't use anymore.
Yeah.
Do you ever assign other types of roles, like, hey, I want you to,
That's a good question.
you know, watch this, or pay attention to this, or, you know, just make them a little more active at the bedside?
So I think the question was sort of what do you do with the other people on the team? Are they just sort of passively there and you're engaging them with it? You know, that's a good question. I never really thought about that. I mean, I guess you could like tell like, hey, you know, the intern is going to present this patient, hey, so-and-so the student, like, hey, I'm going to ask you to do part of the physical exam. I mean, you could sort of do that. I think there's nothing wrong with that. It's probably a good technique, but yeah, I don't do that. Yeah.
If I can jump in, actually, what I've heard some other people have done is the other intern would actually put orders in. So if it's true, like, you know, attending does all the rounding right there at the bedside, if you're calling out orders, like, hey, we should do this and this, then the other intern could be the one actually placing the orders, or at least keeping track of all of them. So the one presenting, the onus is not on the presenter to present and then also do orders or write that stuff down. So that could be an option for them too.
Oh, I like that one too, right? Because usually there's a computer there, so you could be like, hey,
Yeah.
as we're talking about, you can feel free to write orders. I'm like,
Yeah.
yeah, you could do that, yeah.
How far away are we from stopping asking knowledge questions, given that the person can probably pull up the answer on their phone,
Yeah.
using name it, open evidence, whatever, in like a second?
Yes,
Less than a second.
yes. So it's a good question. So the question is sort of like how far away from actually asking knowledge questions is that really worth it when we all know it's at their fingertips? I would say I think it's still important because I think it helps the learner know where their knowledge is lacking and that they need to go look that up, if that makes sense. Because I think that the fact of them, you understanding where their knowledge is, can help you sort of understand, well, what are the things I should push them to learn? And the other reason I think it's still there is because it's still something that you have to fill out on their evaluation and their assessment about where their knowledge is. So I know that's not a great reason, but that still is something that you have to assess in some shape, way, or form. So, yeah.
Thank you so much, Dr. Chang.
Yeah. Thank you.
That's right. I just finished.